announce the next speaker?
The next speaker is Professor Stanislao Rizzo from Italy, from Florence, and we would like to give him a stage and to report his technique, because we all know his technique and is also very fascinated. There are some questions that I would like to ask him afterwards, but let's hear first of all this talk. Please, Professor Rizzo.
Good morning, and thank you very much for your kind invitation. The incidence of a macular hole reopening, recurrent or persistent macular hole after the surgery, is around 3.3%. And the main risk factors are, for example, residual epiretinal traction, insufficient gas tamponade, and insufficient face-down positioning by the patient. And we have many techniques, many surgical techniques. For example, we start with some growth factor, for the TGF beta-2 growth factor and the autologous platelet concentrate to pass through the endotamponades, lighter and heavier than water tamponade. And nowadays, the modern approach consists in inserting alien tissues, for example, into the macular hole. But many times with this transplant of tissues, we have some limitations. For example, they often are two-time surgeries. There are complex surgery techniques, and not always we have available tissues. But first of all, we have unsatisfactory visual outcomes by the patients. For these reasons, we proposed some years ago the use for recurrent or persistent macular hole, the use of a human amniotic membrane. The human amniotic membrane is an immunogenic and not immunogenic tissue. It is not with no need for immunosuppressive therapy. Of course, for this reason, a low rate of rejection reaction. And first of all, it's very easily available. The human amniotic membrane is composed by three layers: the epithelium layer full of growth factor stem cells, the stroma layer, and the corneal layer. The corneal layer has some adhesive properties. It remains adherent to the tissue or to your forceps, for example. And before our proposal, there were many papers about the use in vascular research or human amniotic membrane, for example, as support for human retinal pigment epithelium growth, or for its use in retinal pigment epithelium cell differentiation. And this was our first paper, a human amniotic membrane plug to promote retinal breaks repair and recurrent macular hole closure. This was the first impressive case that we operate. A very large macular hole in myopic eye with retinal detachment of the posterior pole, and the result was impressive, not only in terms of anatomical result, but also in terms of functional result. Last year we published this large series about 36 patients affected by recurrent or persistent macular hole. 7 of these eyes were myopic with very large basal diameters, at least 1,000 microns, and 23 patients were tamponated with SF6, 13 patients were tamponated with air. And it was the surgery. It was a 25-gauge vitrectomy. We passed through the other cannula in order to allow us to use a very large disc of amniotic membrane. In this case, was a disc, or diameter of the disc was at least 3 millimeters, and 3 millimeters is difficult to pass through a 25-gauge cannula. And with the bimanual technique, we use this very gentle and, of course, precise technique to insert the amniotic membrane under the edge of the hole in order to use a very short tamponade as AR or SF66. And this was the intraoperative CT to control the perfect position of the amniotic under the edge of the macula, of the macular hole. This was a recurrence of macular after many surgeries, and we tamponade in this case only by air. And this was the results. These were the results of our study. 100% of 36 recurrent or Rizzo macular hole was found closed at 6 months follow-up. 33 or 36 were closed at 2 weeks. 2 or 36 were closed at 3 months. They were all tamponade only with air. And 1 or 36 need a replacement of amniotic membrane because the amniotic membrane was displaced in IAC myopia eye. There was one on the case, pre-surgery. It was a very large macular, extra large macular hole. It was the plug amniotic membrane. At that time, we used many layers of amniotic membrane. We changed a little bit the technique, also or using nowadays a very thin layer of amniotic membrane. And after 9 months follow-up, we saw that some of the layer of the external layers of the retina were present on the residual of the remnants of the macula of the amniotic membrane. There was another case before pre-surgery. After 2 weeks, there was the plaque of amniotic membrane. After 3 months, there was some tentative of retina to regenerate, and after 12 months, we saw that there were some layers of the external retina. There was another case, large macular with atrophic retinal pigmentalium on the bottom of the macular hole. After 8 months of follow-up, we saw that the external limiting membrane was present over the residual of the amniotic membrane. And in this case, you see, we use a very thin layer of amniotic membrane instead of use a plug of amniotic membrane. This was another case with tissue ingrowth above the amniotic membrane plug, you see, and with formation or layers at the level of the external retina with present of ELM over the plug of amniotic membrane. And also the angio-CT show no difference in the fovea vascular zone and the revascularization of the deep capillary plexus comparing the operated eye with the fellow eye. There was a case of eye with eye myopia. We see a very thin staphyloma on the posterior pole. You see that amniotic membrane after some months at the regeneration of the external layers of the retina or above the plug of amniotic membrane. So, what about the results? We have 100% of closure of the hole with the surgeries, 97% of closure of the hole with only one surgery. And in eye myopia, we have 100% of closure of macular hole with the surgeries and 94% of the closure with only one surgery. Comparing with the other techniques, for example, with neurosensory retinal free flap, the multicenter study had 89% of closure rate of macular hole. Using the autologous ILM transplant, they had 90% of the closure of macular hole, but the number of the eyes was very low. This was our results, best corrected visual acuity. We have the increasing in the best corrected visual acuity, and this result was statistically significant compared with the preoperative best corrected visual acuity in these eyes. In 33 on 36 patients, in about 91%, we have the best corrected visual acuity increased. In 2 or 36, the best corrected visual acuity remains stable. and 1 or 36, the patient operated with displacement or amniotic membrane, the best criteria could to decrease. And for example, in 91% of the eyes, we have at least the improvement in more than 2 Snellen line. In about 70% of the case, we have the improvement in about more in 3 Snellen line in all the patients. And if you see the results of OCTA, for example, we saw that comparing the OCTA in operated eye with the fellow eye, we didn't see any difference, for example, in deep capillary plexus. And the same thing in the fovea vascular zone. We didn't see any difference comparing the diameter of the vascular zone in the operated eye comparing with the fellow eye. Demonstrating that amniotic membrane do not induce a centripetal movement of a tissue, as for example the ILM transplant does. And we saw a very interesting phenomenon that, for example, a greater quantity of an amniotic membrane leads to a better supports in the growth of overlying retinal layers with probably better functional results. And we use also the adaptive optics. We focused our exams at the edge of the amniotic membrane plug, where we saw a greater sensitivity at microperimetry. And we saw two phenomena. One was the hyperreflective ducts, probably recognized by the software as disrupted but present photoreceptor areas. It was some sliding, was probably secondary to some sliding of photoreceptors on the edge of the amniotic membrane. And we saw also some hyperreflective ducts, probably secondary to macrophage cells or retinal pigment epithelium cells. We didn't see any complication, no inflammatory complication, no IOP complication, no reject of the amniotic by the eyes, and no significant difference between that of patients tamponated with the gas and those of patients tamponated with erythea. This means that we can use a very rapid tamponade, very short tamponade in this eye, also to alleviate the prone position of the patients. In conclusions, we study in 36 recurrent macular holes operate with human amniotic membrane. We have very remarkable results, 100% anatomical success, with functional restoration, with some signs of tissue and cellular remodeling. We use air as a tamponade, no need of second surgery, with no adverse event, and very easily reproducible. But first of all, a safe and effective procedure. Only to conclude that we have only a few slides about macular retinal detachment, for example, in myopia eye. And you know this, we use in these problems many techniques, but we use, for example, silicone oil, C3F8, Evident water endotamponade. We published a new approach to use in this case, also in this case, the amniotic membrane, a very large disc amniotic membrane in this case, at least 5 millimeters of diameters in order to close completely, to block completely the macular hole in the retinal attachment, in posterior retinal attachment in myopic eye. You see this was one of the cases with large macular hole retinal detachment and the perfect result of the surgery. We operate 19 patients with 100% retinal attachment and about 95% of macular closure with improving and best corrected visual acuity. In conclusion, amniotic membrane plug is also safe, a simple treatment in myopic macular hole with detachment. I think we can conclude that amniotic membrane is the most perfect basal membrane and the most precise and safe procedure in the recurrence of macular hole. Thank you very much for your kind invitation.
Thank you very much, Professor Rizzo. This very fascinating technique. I saw first your technique a few years ago, and as you used the amniotic membrane to close peripheral retinal breaks in retinal detachment, and it works as well. Very nice. And I would have one question. I tried this technique, and the first difficulty was the absence of the punch. So I just cut a small piece of amniotic membrane, and the amniotic membrane we have in our clinic, they come from France. These are lyophilized amniotic membranes, and they are dry, and as soon as you make it wet, it rolls in, and it's so difficult to unroll it inside the eye. So what kind of membrane do you use? What kind of amniotic membrane do you use?
I think in Italy we are very lucky because we have a tissue bank, and the amniotic membrane coming fresh for tissue bank. It's very, very easy to cut. Also, if you don't have a punch, or you can cut with small scissors. And with two forceps, it's very easy to roll the membrane to use over the macula.
Thank you very much. Susanne, you have to unmute. Press unmute.
One question from the audience to you, Stanislao. It says, good anatomic results correlate with visual gain at what scale? So I think you showed us your data, but perhaps you want to answer this briefly.
The first answer is, of course, we are talking about very, very difficult case. Most of them are extra large myopic eye with more than 1,000 microns, in which we already built the ILM, so we don't have anything to do with to put inside the macula. So for this reason, I think, of course, we have excellent anatomical results, 100% of closure rate, because of the amniotic membrane itself closed the macular hole. But in most of the case, we have at least two lines of improvement in visual acuity. But I have to repeat, I think they are the most difficult case we are dealing with. First, the most of the eyes are very myopic, more than 29 millimeters of length. With sometimes we have an atrophic area in the posterior pole. You know exactly which kind of eye we are dealing with.
I have another question, Stanislao. You know, you said that the amniotic membrane size is created larger, which makes a lot of sense than the size of the macular hole. But these large holes, they are usually very tightly connected to the underlying retina at the edges. So do you actually use a Meyer's fluid technique to lift the edges, and so that you can place the amniotic membrane under it, or how do you proceed?
Is a very good question, because we start the first case to put the membrane over the macular hole. but in some cases, the membrane disappears after the surgery. So, of course, the last technique is to elevate the edge. This, of course, is very gentle maneuver, because with some very gentle spatula, because we project this is a bent spatula in order to elevate at least to have some space on the retina. Maybe the technique of carton is excellent to elevate, but at the end, the maneuver is the same. We have to detach the retina, the edge of the retina from alcohol, because the edge has a very adherent. We need space to introduce the membrane under the retina.
Thank you. Thank you very much.
There is another question from the audience. Which side do you position the amniotic membrane human, and how?
So we measure, usually we measure of course, with the OCT, the diameter of the hole, and we decide to put for example, in 1 millimeter of the hole, we decide to put 1 millimeter half for amniotic membrane. So these are the simple method to calculate the diameter of the amniotic.
No, I think
Does it
meant which side of the amniotic membrane?
Sorry. Yes. We have to put on the retinal epithelium the chorion layer, because the chorion layer has some adhesive properties. It remains adherent at soon you touch the retina. So this is the first tip. Of course, you have to put under the retina, in contact with the retina, the epithelium layer, because it is full of growth factors, it's full of stem cells, so of course it has some regenerative properties.
Do you mark the sides? How do you know it, or do you see this on a fresh?
Some surgeons nowadays mark the sides, but if you magnify your microscope, the chorion layer has some soft filaments coming from the cornea. You recognize very, very well there. And the other tip, of course, the chorion layer remains adherent to your forceps. If you open the branch of your forceps, the chorion layer, the membrane remains adherent, and with the part of it is the chorion.
Thank you very much. This was great. Unfortunately, our time is now close to the end, and I would like to thank again all the speakers, Sophia, Carsten, Lubomir, and Stanislao for this exciting symposium. And I would also tell you that the webinar has been recorded and will be available via the SOE website very shortly. Thank you very much.
Thank you very much, Susanne. And we had over 120 participants during our webinar. This is quite successful. We would like to thank the panelists who presented their presentations and discussion, and we are glad to invite you to the future webinars. Thank you very much.
Thank you very much.
Bye-bye.
Bye-bye.